What's up, ladies and gents? Welcome to another debrief, EP24, where we share our nursing stories. So this week, pretty interesting week. I ended up picking up a 16-hour shift. So it was my night 3 out of 3. And around midnight, they said, hey, we need some help for you to stay over 4 hours. So one cool thing about this hospital, the pluses and negatives, is you have nurses that are grandfathered in for those 8-hour shifts. So one downside is you know, there's nurses coming in at 7, 11, and then 7 a.m. again. So sometimes you might be floating often like we usually do 11 o'clock. But the upside is here, you could pick up a overtime shift, extra 4 hours. With that being said, it's double time. It's like you working 8 hours in a regular shift. So it's 2/3 of an extra shift. You're already there. You don't got to drive anywhere. And it was a cool experience because I stayed till 11 a.m. So I was in the ICU. I was able to see how everything gets done on days, how the rounding in this hospital, which is a little bit different. Some places we worked, the intensivist walks around with the team and they walk room to room. In this case, they're just huddled by the nurse's station. They call a nurse one at a time. You sit down. If the intensivist is new or doesn't know the case, you just kind of give a brief rundown and you let them know what's going on, what do you need, what are your concerns. And that kind of makes sense. Why? For day shift, they ask all these difficult questions because they need to know by 9 a.m. If you get a report by 7:30 a.m., you're doing some nursing care. 9 a.m. comes and you don't know what to ask your intensivist as far as like how the care should go for this patient. So I kind of get why they ask difficult questions. And overall, it wasn't too bad. Drank some coffee at like 5 p.m. or 5 a.m. And just rock and roll till 11. It was nice. Nurses helped me out. Wasn't too bad. Had to order breakfast, all that fun stuff. Overall, good shift. Picked up. Pay stub looked nice. And yeah.
Yeah, ideally, if you're staying over like 4 or whatever hours you do, usually what I do is I haven't stayed over yet, but usually I ask if they need like a break nurse somewhere, like on another unit, even if I'm like in ICU, because it's a lot more chiller to be like a break nurse or a resource nurse compared to having your patients, for example, the extra 4 hours. So I always try to lean on that. So if that's an option, I highly recommend that because you could just lay low, not worry about too much charting, and just help with the patient care.
Yeah, and I know some hospitals you can pick up like earlier. So I think that's a benefit for us working nights. It's probably easier to pick up a shift at 3 p.m. and then stay the 16 and going home because your sleep is going to completely get messed up. You go to sleep at noontime, you just wake up at like 7, 8 o'clock, you stay up, try to go to sleep again. It just feels like a blur.
Yeah,
so
it's tough. How did you feel?
I was exhausted. I'm trying to kind of recollect how everything went down. I was just, blasting some EDM music, driving home at like afternoon time. The sun was hitting. When I got home, when you get home for night shift, you get your energy back, you go do something. But I'm just like, I got to go lay down, man. So slept for like 4 or 5 hours, woke up, did something again, and then try to go sleep at midnight again to wake up the next day and live a normal life.
Yeah, you're definitely tired that day for sure. You're a little grumpy, but it's okay. Forgive you. I made that money.
Yeah.
But I had a pretty interesting case. So on one of my nights, I started off in a step down, and then at 11 o'clock, I got transferred to the ICU because somebody ended up coding down in the ED. And it was an interesting case because the patient seemed to come in for like a CHF exacerbation / fluid overload. They gave him some Lasix. He went into AFib. And then for some reason his heart rate dropped and he basically became a PEA. But what makes it interesting is that in between that time, they were trying to decide, the family and the patient, if he wants to be a full code or a DNR. And he has this cancer. It's called Merkel's cell carcinoma. With it metastasizing, he only had like a 52% survival rate of like 5 years given that cancer. So they were having this debate on whether he wants to be a full code or a DNR, and during that whole debacle, he ended up coding. So they coded him. On the bright side, the code only lasted 3 minutes. They only gave him one push of epi, did CPR, and they brought him back. So when I got him, he was already 8 times 4. So it was the first time I've ever had a situation like that where down in the ED, they're trying to figure out if he should be a full code or a DNR, and he ended up coding. So that's like super scary. Then they brought him up, and he was still a full coder in the computer, but he told me, and his wife told me, that he wants to be a DNR. So I was kind of like a little bit sketched out the whole night because in the computer he's still a full code, and it was downtime. So we couldn't access the computers until like 4 o'clock in the morning, and I got him like around midnight. So it's like I'm trying to just hang out with this guy, trying to hope for the best, so we could change this full code into DNR in the system, just in case something were to happen. But he did well for me during that shift. He was completely antitripsin for the rest of my shift. But the thing is, when I drew his labs in the morning, they were real bad. He was super hyperkalemic. Troponins were shot up like crazy. His FOS was all messed up. His MAG was all messed up. He seemed to be a little more acidotic. And what's interesting is I came back a couple of days later, and the same charge nurse was there, and I asked what happened to that patient, and she said that he ended up passing away, which is very sad. But he knew that he was going to pass away because he told me that he's ready to go. He's like, I don't want anything else done to me. Like, I'm tired. Like, I'm done with all of this. Yeah. Just let me be. And it was very heartwarming because the wife came in and like they were talking for a little bit. She gave him a kiss. They talked for a little bit, and he like told her like, that he's done. Like, he doesn't want anything else done. He's got this cancer, and he was very content of just passing away. And he was not fixated, but it's almost like he knew it was coming, and she knew it was coming too. So she wasn't crying or anything at that point in time, but she was just trying to make the best out of the situation. She told me like, hey, we want to make sure this is a DNR. We don't want any compressions on my husband. And my husband's like, I don't want any compressions on myself. So we're just kind of like wishfully hoping he's just going to have a good night. And he slept majority of the night. He was just an excruciating pain. He just got his chest worked down for 3 minutes. Luckily, the CT showed that nothing was broken. Every sternum was intact. Ribs were intact. No issues with that. But it also showed a worsening of his cancer. So that 52% probably went down to like a good 10-20%. It was all over his body. It was in his lungs. It was in his liver. It was all throughout his body. So he probably went a nicer way than he probably would have in the future. But it was just like kind of humbling to see that sometimes people could sense when they're gonna pass away, and they're just content. Like, he had no regrets. The wife was telling me about how much good times they had, how good of a guy he was. He was Brooklyn. He had a thick Brooklyn accent too, so that was pretty cool. And we just talked a little bit like about life and about like his kids, about his family and all that kind of stuff. So it was really, really cool. But like I said, it was super interesting to like see that like this patient like knew that this was probably his last time on this earth. He even said that, hey, can everybody just come by tomorrow and I want to see him. So he like legit knew in a way that he's not gonna be here any longer.
It always makes your nursing experience a lot better when the patient is with integrity, the family's content, and that transition is smooth. A couple nights ago, that one guy that we talked about with the ETOH withdrawals, I ended up making him comfort care, and he died the first 3 hours of my shift. And he had really bad epitexis. He was like in a non-rebreather. There was blood all over. They kept wiping it out. He kept nose bleeding. He had a clot in his mouth, which I didn't even suction out because he probably would have kept bleeding. The towels were all drenched. And when, he was started on a dilaudid not PCA, just a basal, right? And when he passed away, it was the opposite experience that I had, where the father was like upset. He was kind of hitting the bed. When I gave him a box of tissues, he was kind of pissed and grabbed it. And I understand what he's going through. He was there for a whole month with his son, trying to save his life, trying to do the best for him. And even the son said before he passed away that I wouldn't be able to do this without my father. So younger guy has a 2 and 8 year old, so it makes the situation a lot harder versus somebody with living in integrity and being peaceful. But that's just the beautiful experience of nursing that we see. So that was the first patient on this contract that I seen transition to comfort care and passed away.
I admitted him initially in the ICU. I remember he had a very bad ascites, like very rounded abdomen, right? And that's what's crazy, is seeing like alcohol take someone's life, because it's affects your liver. So that's why he was bleeding so much. You can't clot. You go into DIC. It's a nasty thing to go out with cirrhosis or alcoholic liver disease, like liver failure. It sucks. There's nothing we could do to you, because I know in the beginning they were considering of giving him a liver transplant, but he was not a candidate anymore, just because it was just so bad. Like, his other organs were already shutting down when he came to the hospital. Like, his kidneys took a giant hit. He was just very, very, very sick. And there was nothing they could do for him. Like, liver transplant was completely out of picture, just because he was having like almost end stage like renal failure, like end stage organ failure. Everything was just getting shut down because you can't filter your blood properly because liver's shot, and your coagulopathies are all through the roof. They're all messed up. You can't clot properly, and it's just a cascade of just problems and problems and problems.
It just makes you wonder, guys, where people have moderate alcohol consumption, they live a long time, 70s, and somebody that's just in her 40s and passes away from this, like, how severe is your drinking habit? Where's your family with this? Like, why aren't you seeking help? Like, I just don't understand the mentality of consuming so much booze, but it's of course an addiction, and it's hard to understand.
Yeah.
And other than that, in my shift, has been just pretty uneventful. Like, I've had a lot of confused patients that I was just doing a lot of, like, house sitting and nannying, and hey, stay in bed. Literally, there was a funny meme that I saw yesterday, just like my shift reminding my patient with a Foley every 15 minutes that he could go ahead and pee. And he's like, I got to get up to use the bathroom. That's been like me for like Q12 to 3 nights in a row. I had one lady that had a Foley, the other time was taken out, so she was just soaking up the bed. And the third time, which was yesterday, that guy just kept yanking on his Foley trying to get out of bed. But one cool thing I learned was about a disease process called alpha-1 antitrypsin deficiency. So this is a genetic disorder, and it seems like both the mom and dad had it, which passed it on to her. And alpha-1 antitrypsin is a protein that the liver produces that protects the body and tissue from being damaged when you have like infectious fighting diseases or agents. And it's basically lubricates the body, protects you from the immune system. So given her case, the life expectancy is usually 6 years old because your lungs give out. So she had a lung transplant in 2015, so she was able to survive a lot longer. She does have like CKD stage 4 because that disease affects the kidneys and lungs. Unfortunate. So I learned that disease process, which was cool, but she just had all other stuff going on. I don't know if it's related to osteoporosis somehow, where you have weak bones due to this, but she basically had a fracture, ulnar fracture, went home, was mopping the floor, missed her ortho appointment, fell down again, fractured her hip, and in a lot of distress. On top of this, I guess she had an allergy to narco before, where she took it before and she was going crazy for a week. In the other hospital, they gave her narco, so she got brought in for multifactorial metabolic encephalopathy. So they stopped her antidepressant medications, all this stuff. She didn't get any narco, only Tylenol for her pain, and was trying to get better.
Yeah, man, it's crazy how I don't want to laugh, but how much
it's okay,
how much
man.
falls happen in the world, dude. It's so crazy, right? Like if you don't work in healthcare, you don't understand how many people fall and break some bones. Like literally people that need like a new hip, a new knee, bilateral hips, femurs, everything like that. It's like when I was in the hospital, I'm like, whoa, like old people fall a lot. Old people fall a lot, and that shit causes a lot of trauma.
Yes,
and sometimes they die just from a fall. It was like mind blowing to me. When I first got in the hospital, I'm like, oh shit, this is happening from people falling. I was like super surprised.
Yeah,
it's crazy. But last night, when I worked with Matt, I had a pretty interesting case. We had I don't want to get too much into background because I'm not sure how deep that'll be into HIPAA, just because she has a specific history. You know what I'm saying? I don't want to say anything, but whatever.
Not whatever, Ryan. Getting this podcast closed down. Watch what you say, bro.
Right. So we had a patient come in, a quadriplegic, from a very, very young age, came in and went into basically hypercapnic respiratory failure. The patient was intubated. Then that patient was extubated and then re-intubated a second time, and then extubated the patient a third time. And I had her a day after they extubated the patient the third time.
She was a 1-to-1.
Yeah, she was a 1-to-1 because she was a lot. She was a lot. She was a lot of work because she wasn't doing very good to begin with. And the thing is, we're trying everything in our power to prevent this patient from getting re-intubated because this would be the third re-intubation and it's going to be a trach. And I don't like people get trachs because it sucks. It's a lot of times we see the worst of them and they don't do very well because it's the ICU, and we don't really see a lot of people, get better, especially in these kind of circumstances. So we're trying everything in our power to not have her get reintubated. Her major problem was anxiety. Super anxious. I gave her some Atarax, helped a little bit for sure, but it was just her just constantly just being anxious. She kept asking me about how her numbers are doing, okay, and her numbers were fine. She was standing well, of course on a BiPAP, 40%. I think she was 14 or 11/4 or something. I forgot what it was. 11/4, she was 40%. So that's like a decently high setting, right? It's not the smallest setting that you could put somebody on, and just super anxious. And the thing is that once you took the BiPAP off, she would desat within like 30 seconds, and she had a very weak cough. So I was giving her, like I was coughing her like how you cough a person that's like paraplegic or a quad, where you push on a diaphragm. So she was coughing, but it was very weak. So I literally had to push on her diaphragm to put more pressure,
stimulate that
response. Yeah. So to get that out, and she still was able to get the phlegm out. And then they were suctioning her so much during the day, where when I suctioned her, anti-suctioned her, there was just so much red blood. And the thing is, she has a bleed going on somewhere because her hemoglobin dropped during the day. They had to give her 2 units. It was stable on my shift, but I don't know if she has like imagine if she had like an esophageal varices or something, or a nick the varices somewhere. Like, that's super scary. She's had like bright red blood coming out of there, and I had to suction her like 3 or 4 times overnight, and it was just like staying there. I couldn't just like do anything because it was super stressful. And then plus she had so she couldn't pee, so she had literally like a hole in her belly. I forgot what is on top of my head, but she had a little hole in the belly that I had to literally straight cath. She has like a pouch there, and this pouch, cool. Stores urine. So I literally had to pop a straight cath in there, an ileal conduit it was called. Ileal conduit she had, and I was literally doing that every 2 to 4 hours, depending on just guesswork.
So what organ were you hitting? Ileal conduit. So you were taking urine out of the ileal conduit?
Yeah. So
does she pee?
No pee. That's how they pee out.
So the pee's going there.
So the pee's chilling there, and it's like a little hole. Looks like a belly button.
I'm just curious on what these surgeons did to create this little pouch. Where the ureters are pouring urine there, huh?
Yeah, I don't know.
Fascinating stuff.
Yeah, but it's literally a hole, and nothing comes out of the hole until you puncture it. Then it drains. So I don't know if there's like a little like a closing valve, like a valve or something. But yeah, and like her WC jumped up from like 16 to like 29 point something, and she had no fevers, so she's going septic. She came in for pneumonia, so it was just a giant slew of problems that are just exacerbating her anxiety and her respiratory issues. And plus, they just pulled a chest tube out of her, so she just had so much going on, and it was just like me trying to just ease her anxiety, and it was just hard. Because
what's interesting about her is she had that traumatic experience when she was younger. So I wonder how much of that PTSD is getting transferred over into her everyday life that's affecting her, right? When she had that accident at the pool, right? So if you have like this drowning experience, what if like you having air hunger is you reliving that experience of not being able to breathe? So like it's like childhood trauma that keeps getting brought up, and she's she can breathe, but she's just doing her thing on BiPAP, and it just makes things worse. And these are usually our freaking patients that get intubated, and we have such a hard time extubating them and keeping them out of getting reintubated. Yeah,
it's tough because she's a quadriplegic, so technically her lung volume isn't going to be the best in the first place, right? You're not running, you're not really testing your lungs. You're just laying there and just almost like the minimum breathing you're doing. And then on top of that, you get pneumonia. And on top of that, you get a pneumothorax. So it's like how resilient are your lungs if they could bounce back from that?
Yeah.
Like how healthy are those lungs, because they're not getting tested. Like we have very healthy lungs. We're athletic people. We train. We work out. We go to the gym. We're very healthy. So we could take a lot of strain. But this patient can't in the first place because she's doing that bare minimum
to begin with.
Yeah. So it's just like all this cascade of issues, and now you throw on sepsis on top of this because of the increased WBCs and a bleed somewhere because your hemoglobin dropped. It's just everything's coming all at once, and I don't know. She wasn't looking too hot, dude.
I had my other C19 guy, which is nonverbal. He suffered a traumatic brain injury when he was in his early 20s. So he can't do anything. All he could do is just move his left hand, and he had such bad, like his whole left lung was whited out, and you can't tell him to cough because he's not alert. So it's like, how do you get this guy to clear his secretions? You're trying to, do a gag reflex and get him to cough. And the worst thing is, once you intubate somebody that's anal times 1 and can't follow commands and is, has a TBI, what's the next steps? Trach and peg. Yeah. So they're trying so hard to prevent that from happening. I don't know what's going to happen with this guy because he was on a non-rebreather maxed out in 15. Oh, I'm sorry. He was on high flow maxed out and a non-rebreather maxed out. And you can't, you only could do pulmonary toileting so much and neb so much, but he can't do it himself. So that's unfortunate, man. And the worst thing about this that like creeps me out. So when he came in, his sodium was 188. I've never heard of a sodium that high till I took care of this guy, but it's possible. So you have a mother that's taking care of him. She doesn't work. She gets money from the government for taking care of him. And it looks like he already doesn't have the best quality of life given his circumstance of having a high sodium. So now we're going to intubate this guy given his case. You're going to trach and peg the poor guy. He's already, who knows if he's there cognitively giving his scenario of the traumatic brain injury. And, the mom's going to want him to be a full code and do everything done because she's getting like money from the government. Maybe she really loves him, right? Like I'm just painting a scenario here, but it's just so sad for these patients where we're just taking them through the craziest spectrum of healthcare to keep them alive. And like, what is the quality of care that we always talk about? And is it the best for this person? Because he's going to be in and out of the hospital. Yeah.
And you can live for a long time, but like you said, the quality, he's just a body, and it sucks because I had a case like that back in Chicago too, where we had to get ethics involved because the family member was just cashing checks. This patient had just wounds everywhere, super dehydrated, just not taken care of, and the patient family was just using it just for income. And it's crazy how that works. The patient was almost basically brain dead, and it was just wasting away just for money. It's really sad how you can see that kind of stuff, man. But that's kind of how the world works sometimes. That's the reality of things. Yeah. Same way when you have like SIDS or like shaken baby syndrome, all that kind of stuff. When I used to see that like in clinicals back when I was in nursing school, like you can't comprehend or realize that this stuff happens until you actually see it, because especially with like infants, like you wouldn't think that who would possibly in their right mind take an infant that's crying and shake it so hard where it severs their spinal cord and now this infant is paralyzed. Like there are some really crazy situations out there in the world, and it's kind of nice, you could say, that we see this because we do get a really good taste of reality. But it's also very sad because we got to deal with this reality too.
Yeah, I was working the shift yesterday. I'm just like, dude, honestly, from all the careers in the world, I think nurses have the craziest experiences. Shout out to the nurses. And we deal with the most. Yeah. Because we see everything. The doctors deal with the physical, the mechanical part of getting this guy alive. You have a surgeon, which is a crazy profession as well. They cut up a patient open, high risk, but they don't see the emotional side, the draining side of everything. And we get the full spectrum of, the patient post-surgery, freaking bowels, urine, vomit, blood. And it's just like, we have such an insane role. Yeah. So just like, nurses coming off their shift or having, a crazy shift, like pat yourself on the back. You guys are freaking amazing. We are amazing for what we do. And I don't think there's not a lot of people in the world that could handle what the hell we do.
Same with RT, dude. If sometimes I don't know how to do with my patient, not like struggling to breathe, I'm like, hey, can somebody call RT? Hopefully they can figure it out, not to like put down a physicians or anything like that. Physicians usually come by when we don't know what to do. And if you don't know what to do, it's when we don't know what to do.
Yeah. All right, guys. Thank you for this debrief. Camera just died. We're going to cut it short. We'll see you guys on the next one.
See you guys.
Peace.